Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckville and I will be serving as your program moderator. Well, thank you so much for submitting your questions in advance of tonight, and the questions you'll hear me asking the panelists are all submitted right from when you registered for this webinar. If you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you'll see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital, university guidelines and privacy, we are unable to comment on specific cases. Likewise, if you're experiencing any symptoms that may require immediate medical attention, please consult a medical professional. Well, with that, I want to go ahead and introduce our panel joining us this evening. So our neurosurgery and spine surgery experts are Dr. Tony Stefanelli, Dr. Christian Holscher, Dr. Kyle Matthias, and Dr. Michael Yoon. Well, thank you all so much for joining tonight's discussion. I know we're going to have a great conversation, but first, let's go ahead and just have each one of you provide a little background information about yourself and introduce yourself. So, Dr. Stefanelli, we will go ahead and start with you. How are you doing this evening?
I'm great, Sarah. Thank you for having us again. This is great. So yeah, like Sarah said, my name is Tony Stefanelli. I am a neurosurgeon at Jefferson Hospital. I did all my training at Jefferson, so I went to med school here, went to residency, did a fellowship in complex spine and deformity correction, and continue to work here. So it's a pleasure to be on here, and hope everybody gets something good out of this webinar tonight.
Absolutely. We're excited to have you. Thank you. Okay, Dr. Christian Holscher, how are you doing?
I'm good. Thanks for having me again. Been my pleasure to have been here a couple times now. I am much like Tony. I also did all of my training at Jefferson, or at least my residency training. Originally from Bucks County, Pennsylvania. And so I've been in this area, not in the greater Philadelphia area for about 20, 25 years now, but professionally now in South Jersey for the last 4 years or so, based in Washington Township, but covering, everywhere from, Cherry Hill down to Washington Township. So I'm happy to be here, and yeah, excited to get started.
All right. Well, thank you for joining us again. Okay. Next up, Dr. Matthias, how are you doing this evening?
I'm doing okay, all right. Thank you for having me again for an event like this. It's a pleasure to be here. I've been at Jefferson since 2018, and right now I'm located more in the Northeast area, covering the campuses of Jefferson Torresdale and Jefferson Bucks. And it's a pleasure to be here, and happy to go over the questions, and that's it. Yeah.
Absolutely. Well, thank you for joining us. And finally, Dr. Yoon, how are you doing? Oh, and I think you might be on mute.
My apologies. Thank you again also for having me. I've been here at Abington Hospital for almost 24 years now. I did my training at Temple University. So I've actually been in the Philadelphia area for almost 30 years. But Abington has been my home. Do lots of degenerative spine up here. And excited to answer any questions and get to the webinar.
Absolutely. Well, I know that we have a lot of questions to get to. So without further ado, let's go ahead and just dive into our discussion for tonight. So Dr. Matthias, we will kick it off with you. First question for the evening. What causes spinal cord compression?
Yeah, that's a very good question. I would like to start by saying that there's a very important difference between spinal cord compression and nerve compression. So spinal cord compression would be anything, any kind of mass or any structure pushing against the spinal cord, which would most likely be at the cervical level, thoracic level, and maybe the very top of the lumbar level. That's where the spinal cord ends. So any kind of mass like a tumor or a disc herniation or even a hematoma an infection causing a fluid collection, any kind of mass pushing against the spinal cord would cause spinal cord compression. And then all the symptoms coming from spinal cord compression, which could include weakness or even paralysis, sensory changes, bladder and bowel dysfunction. Those are the major symptoms of spinal cord compression.
Okay, well, thank you for defining that for us. All right, for our next question here, we're going to talk a little bit about some of the new treatments. So Dr. Yoon, is research leading to any new innovative treatments?
Yes, so traditionally, surgery involves decompressing the spinal cord and possibly having to fuse the spine with rods and screws. There are newer ways of performing these types of surgery using minimally invasive techniques and by using robotic and navigational assistance to help safely place the spinal instrumentation. These are the biggest and best changes that I've seen over the years I've been in practice. And these techniques continue to be refined. Oftentimes, spinal cord compression requires urgent surgical attention. And, there is research being done for medical treatments for when the spinal cord has already been injured. But all in all, the techniques for surgery have been pretty standard for many years. It's just that we're refining these techniques to be, again, less invasive and more safe with the technology that's coming out.
Okay, well, exciting to hear. Thank you. All right, Dr. Stefanelli, we will turn to you now to talk a little bit about recovery. So what is the recovery like for spinal cord compression surgery?
Sure. Thanks for the question, Sarah. So it kind of depends on a few things. As Dr. Matthias alluded to earlier, the spinal cord exists in the cervical spine, the thoracic spine, and in some folks, the very top of the lumbar spine. So the recovery from surgery for spinal cord compression generally depends on what type of surgery we're performing. So without keeping it too long, so in the neck, oftentimes we can either go from the front of the neck or the back of the neck, depending on a couple of different factors, or sometimes we have to go from both. Usually when we go from the front of the neck only, oftentimes patients can go home that same day or the very next day. When we go through the back of the neck, it's a little bit more painful surgery. So we oftentimes keep patients in the hospital for a few days just to get pain medicine. And they'll generally leave the hospital after like 3 to 4 days. Same thing in the thoracic spine. We can't go from the front in the thoracic spine, generally speaking. So we have to either go from the side or through the back. And again, similar recovery to the back of the neck, and same thing for the lumbar spine. So it really depends on the type of surgery. There's a lot of different nuances to that, but generally speaking, most people are in the hospital for anywhere from 1 to 4 or 5 days. And then depending on surgeon preference, they may leave the hospital in a collar if they've had surgery on their neck, and that collar will stay on for a period of time, depending on the surgeon and the surgery. And then we usually recommend patients start some physical therapy a week or 2 after surgery to kind of get their strength built back up and so forth. And some patients will even go to inpatient therapy right after their surgery, because oftentimes, as Dr. Yoon had said, a lot of times these surgeries are more urgent because people have had damage to their spinal cord. So they have difficulties walking or ambulating, difficulty with their hands, fine motor stuff. So those patients will often go from the hospital to an inpatient rehab facility to get their strength built back up once we relieve the pressure on the spinal cord.
Okay, thank you for painting that picture for us. That's helpful. All right, Dr. Holscher, we will turn to you now. Next question here. What are the best activities to help with spinal cord compression and to avoid further injury?
Yeah, so it'd be a very, very common thing we get asked. I'd imagine this question is geared more towards like, how do you prevent spinal cord compression in the first place? Once you have significant spinal cord compression, that is typically a surgical problem, as I think has been alluded to a couple times here. the best means to try to prevent any issue in your spine. Dr. Matthias had briefly touched upon causes of spinal cord compression, which can vary. There are certainly several different reasons why you could have spinal cord compression, but I think what we're primarily focusing on for this webinar is really kind of the bread and butter case, which is essentially arthritis. Like the term degenerative disc disease is this kind of fancy term we use in spine, but it's no different than having an arthritic hip or an arthritic knee. The spine is full of joints, and essentially that term means arthritis. And that leads to progressive collapse of the disc, drying out of the discs, thickening of the ligaments, overgrowth of the joints, and all of that can kind of circumferentially impress upon the spinal canal and cause spinal cord compression. So the best thing you can do to try to prevent that and the ensuing symptoms and kind of slowly progressive spinal cord injury that ensue are to have strong paraspinal muscular support. So staying fit and active, and just overall having good muscle strength in the postural muscles of your spine, which are not easily worked out. Like even people that are very active and fit may not necessarily have good strength in their postural paraspinal muscles. And so the more muscular support the joints have, like any other joint, the less stress and the less rapidly we will develop arthritic changes in the discs and joints of the spine. So some attention to kind of core strengthening, paraspinal postural muscle strengthening. And then, of course, just like the same stuff that you always hear, which is overall being healthy, right? Eating healthy, keeping your weight under control, not smoking, stuff like that will all help your spine to whatever degree, you can accomplish it. But I'd say number one is just strong paraspinal postural strength. So yoga, Pilates, physical therapy, workouts in the gym really directed towards spine, paraspinal postural muscle strengthening.
Okay, thank you. Helpful to hear some preventative options. Thank you. All right, let's talk a little bit now about some non-surgical treatments. So Dr. Matthias, can you talk to us about these non-surgical treatment options for spinal cord compression, such as injections?
Yes. So going back to the difference between cord compression and nerve compression, right? For example, if you have sciatica pain with a lumbar disc herniation, the nerves can be much more forgiving than the cord. So whenever we have lumbar problems, we tend to really exhaust non-surgical strategies such as injections. So if they have sciatica pain, we tried physical therapy, medications, injections. When we're talking about the spinal cord, the situation is a little bit more complicated because if you wait too long, the damage can be permanent. For example, if you have a large disc herniation pushing against the spinal cord on your neck, that can cause significant trouble with coordination, hand weakness, trouble with balance. So whenever we have a situation like that, even because there's not as much space as the lumbar spine, for example, going for injections can be, number one, sometimes not effective or even dangerous if there's not enough space to inject medication. There are some situations where there's infection around the spinal cord in the spine, for example, where we initially treat with antibiotics and not necessarily go straight for surgery. But overall, I would say whenever there is cord compression, we tend to be more aggressive, leaning towards a surgical intervention than non-surgical strategies.
Okay, thank you. All right, Dr. Yun, we will turn to you for the next question. Can you talk a little bit about the relationship between spinal cord compression and herniated or bulging discs?
Yes. If a disc, which is the shock absorber between the larger bones of the spine, starts to bulge out centrally enough, it can cause direct compression of the spinal cord. When this happens, a person can develop weakness, numbness, or tingling in the limbs. Whether or not the upper limbs or lower limbs are affected depends on the level at which this disc bulge occurs. as some of my colleagues have pointed out. For example, if a disc bulges out in the thoracic spine, which is the mid-back where the ribs come off, a person can develop symptoms usually affecting the lower extremities. However, if a disc bulges out more towards one side, then the spinal cord may not be compressed at all, and it may just be that nerve root that's exiting. And nerve root irritation often causes radiating pain. For example, in the cervical spine, if the disc is not bulging centrally into the spinal cord itself, but off to the side, and just pinching the exiting nerve root, then you can get that pain radiating into the upper limb. So again, it's very important to make that distinction between whether the spinal cord itself or whether a nerve root coming off the spinal cord is being pinched by a bulging disc, because the treatment options are different, and being able to wait on one such as a pinched nerve is okay oftentimes, and we treat that conservatively. Whereas again, if it's a spinal cord that's being pinched, it's much more serious and usually requires urgent attention.
Okay, thank you. Definitely an important distinction there. All right. Before we move to the next question, just want to say thank you to everyone who has been submitting their live questions, and we will turn to the live audience questions in just a little bit, but feel free to keep submitting any questions throughout our discussion as they pop up for you. All right, Dr. Stefanelli, this is the next question for you. Talking a little bit about pain here, can you correct the pain of spinal stenosis?
Sure. So, that's a very good question. And again, going back to what Dr. Matthias and Dr. all of us have been saying. So there's another distinction to be made when we talk about pain when it relates to spinal compression. So we talked earlier about there being the spinal cord and the cervical and thoracic spine. So generally, when people have spinal stenosis at the spinal cord level, this tends to actually be painless. So oftentimes it goes missed or underdiagnosed because folks generally are not in pain from it. They may have some mild neck pain or mid-back pain just from the arthritis in their spine, but not from the actual spinal cord compression. So generally when the spinal cord is compressed, it's a painless loss of function that it causes over time. If we talk about the spinal nerves, which are in the low back or the lumbar spine, when folks get compression of the nerves, this generally causes pain, significant pain, something that we call neurogenic claudication. So again, fancy, stupid medical words that mean when all the nerves are compressed in the low back, people tend to describe symptoms that are exacerbated or worsened when they're standing or walking for long periods of time. So for example, they'll say they have intense pain in their low back and their legs, their thighs and calves, and the pain can get significantly worse as they ambulate. And they oftentimes have to sit down or lean forward to relieve some of those symptoms. So the pain that happens from lumbar stenosis, we are often very good at correcting. And correction can be something as simple as removing a single piece of bone to free the nerves up, or it can be as significant as doing a large scoliosis correction for the same problem. It really, there's many nuances depending on the particular patient's problem. But I think one thing is certainly important to keep in mind, and I tell all my patients this, and I'm sure the other folks do as well. Yeah, there's no surgery in the world that can correct 100% of your pain, right? It's just not realistic for most folks. Now, every now and then, yeah, that does happen. You have a young person who has a disc bulge and they have sciatica from it. Yeah, oftentimes they'll get 100% relief. But if you're someone who is in their 70s, who's had long-standing arthritis in their low back, we can oftentimes do a significant improvement, 70, 80, maybe 90% pain reduction by releasing the nerves or the pressure on the nerves. But to assume that any surgery, generally speaking, will give you a full pain relief, 100% is oftentimes unrealistic.
Okay, well, thank you. And an important call out to keep in mind. So thank you for that. All right. Dr. Holscher, we will turn to you now. How can we slow the progression of spinal stenosis?
I think this is, more or less, to be honest with you, more or less the same question as I had a little bit ago. Like, you have two options, and one is essentially to drink from the fountain of youth and don't get old, right? Which is obviously impossible. Otherwise, the degenerative disc disease and the things that are the typical causes of spinal cord compression that we would all be thinking about are essentially just progressive arthritic change in the joints and discs. The discs are joints, so the joints of the spine. And so, it would be a similar thought process to, like, how do I not get an arthritic hip, or how do I not get an arthritic knee? And it's really the same thought process, right? The more overall fit and active and healthy you are, the more you challenge your body with exercise and some reasonable degree of, of I don't even know what the right word is, like challenging the fitness of your paraspinal muscles, the more support, the less stress of just everyday upright posture, right? Just think about your cervical spine. The discs and joints of your spine are responsible for a tremendous amount of motion in terms of degrees, lateral bending, flexion, extension, rotation. Like, your neck can do a lot of mobility, and it's always supporting a bowling ball. So if you have really weak paraspinal postural muscles, like, a lot of that responsibility, a disproportionate amount, will fall on the discs and the ligaments and the facet joints of the spine, and you'll get progressive, what we call spondylosis, or the more routine term for that is degenerative disc disease, which again is just arthritic change in the spine. So at the end of the day, like any primary care or anybody else in medicine would lecture you about, it's the usual stuff: eat well, nutritious diet, don't smoke, control your diabetes, be active, be fit, to whatever degree weight loss is possible. All those things help, and will help you limit the progression of just the natural arthritic changes that happen to all the joints in our body.
Okay, thank you. A reminder how important some lifestyle changes are. So appreciate that. Okay, Dr. Matthias, we will turn to you now. This person who submitted this question says, can I get a spinal compression if I had a lumbar spinal fusion?
So yes, regarding that question, so the spinal cord, for the vast majority of people, ends at the transition between the thoracic and the lumbar spine, and for some people, at the very top of the lumbar spine. So the lumbar spine, we have the vertebral body of L1 to L5. So for majority of the patients or the people, the cord, the very end of it, will be around the L1, L2 level. So, and some, it's rare, but we see it sometimes in different patients and different people, the spinal cord being a little bit lower. That's a condition called a tether cord, where the spinal cord ends lower than usual. For people and patients in that situation, if you do have a lower spinal cord, and if you're getting a fusion at that level, they can definitely have cord compression. If, for example, for arthritic changes like developing canal stenosis, that's one condition, or if after the surgery they have a post-operative hematoma or even an infection, it can cause cord compression. However, I need to emphasize that cord compression in the lumbar spine is an extremely rare condition because of the typical anatomy of the majority of the people.
Okay, thank you so much. All right, Dr. Yoon, let's talk a little bit about spinal stenosis. What are the benefits and risks of surgery for spinal stenosis? And are there any new procedures to treat it? And I think you might be on mute.
Yeah, again, we have to make that distinction regarding where the stenosis is occurring. And so if you have stenosis in the lumbar spine causing pain, we can certainly help patients oftentimes by decompressing the lumbar spine. And sometimes if you have some instability there, we can do procedures that involve not just decompressing, but stabilizing. And that can help again with pain in that area. If there is stenosis in other regions of the spine that are causing spinal cord compression, again, decompressing can help with restoring that function and certainly helping prevent worsening of that condition. Having said that, of course, there are risks to surgery. The risks include, bleeding and infection, as with any type of surgery. Because we're working on the spine, there are risks of injury to the spinal cord and or the nerve roots, which can result in weakness, numbness, or even increased pain. Those risks are generally low. There are also risks associated with undergoing general anesthesia. Surgery is not recommended if the risks in any given patient are very high. For example, if you have a very serious heart condition or your heart is very weak, may not be able to tolerate that, and so surgery might not be recommended. I'm not aware of entirely new procedures for the treatment of spinal stenosis. However, as I mentioned before, there are techniques that are less invasive, and placement of instrumentation can be more accurate with the use of robots and navigation.
Okay, thank you. And yeah, exciting to hear some of those non-invasive techniques. So thank you. All right, Dr. Stefanelli, we will turn to you. Is disc replacement an alternative to full cervical spinal fusion? What are the non-surgical treatments for full cervical spinal fusion?
Yeah, so that's a good question. We oftentimes will get a lot of patients asking us about disc replacement, or another term people may have heard it called disc arthroplasty. Essentially what that procedure involves is it's a procedure done from the front of the neck, where we go in, we remove the disc, which is oftentimes putting pressure on the spinal cord or the spinal nerve roots exiting, causing radiculopathy or shooting pain down the arms. And then instead of a traditional, what we call interbody, so that's a device that we put between the two bones, and then we fuse them in place. So we either use cadaver bone, or sometimes there are implants that are made out of metal or different plastics and so forth. Rather than doing that, which is a traditional cervical fusion, we put in what's called a disc replacement. So there are a few companies that make them, but essentially the idea is that it's a mobile device that replaces the disc. So it has some angulation to it, so it can move in the same way that your spine normally moves at that level. The thing to keep in mind here is that the disc arthroplasty is not a good option for a lot of people, or it's only a good option for a small subset of people. So generally, and again, there are different situations where they're very nuanced, but the general idea of a disc arthroplasty is it's good in patients who are younger. So we're talking folks in their 30s and 40s, maybe early 50s, that do not have a lot of arthritis in their spine. So patients sometimes will have a single level or two levels of disc bulging, but not have a lot of what we call osteophytes or overgrowth of bone. And those are patients that are better candidates for that type of procedure. And also, generally, we recommend it in patients who do not have a lot of neck pain or mechanical neck pain, meaning that when patients move their neck, they have a lot of just pain in their neck. Because the whole point of it, there is some instability generally when that's the case. So we don't like to replace the disc. We like to pursue a fusion. So it's a lot more nuanced than that. And certainly if if patients are interested in it, they should certainly discuss it with their surgeon. But it's important to keep in mind that it's not a good option for everyone. There's only a very small subset of folks that it's a good option for.
Okay. All right. Thank you. Okay, our next question here, I know that we chatted a little bit about new techniques on the horizon. So Dr. Holscher, can you describe what are some of the newest and most promising techniques for treating degenerative disease of the spine?
Yeah, and so it's been mentioned, a couple times, and what I would say is it's really just kind of new variations of the same thing, right? It's it's not necessarily so much new surgeries or new, the goals of surgery, so to speak, have been the same forever. It's to some degree when you have surgery on your neck or your back or your spine, the goals of surgery to some degree in some combination are decompression of nerves, stabilization of an unstable segment, possibly realignment, and possibly fusion. Like not necessarily every surgery encompasses all of those things, but those are kind of, I had one mentor that used to call those the four pillars of spine surgery, right? And so every surgery has some combination of those elements. And so like new techniques, so to speak, or new technology are just new and different ways of accomplishing those same goals. And that might involve smaller incisions, that might involve more accurate placement of instrumentation. So by instrumentation, we mean screws and rods and grafts and things that are used to stabilize and facilitate fusion. It can mean, more advanced research and development, so to speak, like better implant material science that fuses better with the adjacent bone, or that is less likely or subject to material fatigue and breaking of the implant itself. So the things that we commonly, that we are commonly talking about in spine surgery are less invasive. So trying to avoid the traditional open midline incision where we really have to dissect a lot of the muscles of the spine to get access to the spine. That's still the bread and butter approach to everything in spine. But smaller incisions, to some degree, maybe endoscopic, so the use of kind of small incisions with cameras, much like you might have heard about laparoscopes or abdominal surgeries done with cameras. There is a small subset of spine surgeries now that can be done with cameras and small incisions. The term robotic has come up. What robotic means, a lot of patients are a little bit confused as to what robotic surgery means. It's not as cool as it sounds. Like it's not like there's, some android standing next to you doing surgery with you. Like it just means that you use a machine that facilitates typically more accurate, like predetermined place along a predetermined trajectory placement of screws and hardware in the spine. So it's a tool that still has to be manipulated by a surgeon in the OR to help make sure that the trajectory of a screw, for example, is where you want it to be, or where you intend it to go. Intraoperative CAT scan and the use of what we call navigation is another tool kind of in the same vein that allows us to make sure that we're being as safe as possible with instrumenting or putting screws and cages and implants into the spine. And so like those are the primary, I would say those things are the typical focus of innovation in spine surgery. The other side of it that probably gets a little bit less attention is, like I said, the material science and the material that we're making screws and grafts out of bone grafting material, whether it's cadaver bone or synthetic bone graft that is better able to stimulate bone cells to grow and make new bone and facilitate diffusion. Or as Tony had touched upon, there's a small subset of patients that are maybe able to avoid fusion and have, a disc replacement, for example, that accomplishes the same goals of nerve decompression, but doesn't require, changing necessarily the biomechanics of the spine.
Okay, well, exciting things for sure on the forefront, so thank you. All right, before I dive into the next question, just to plug that we'll be getting into our live audience questions in just a few minutes. But first, Dr. Matthias, I want to turn to you. This question wants to know, how do I know when I need surgery for spinal cord compression?
Yeah, thanks, Sarah. That's a very important question. I'm gonna split into major group of symptoms. The first one is related to the cervical spine or the neck, whenever you have cord compression on your neck. So patients that start noticing trouble with the coordination or the strength of the hands, trouble with fine movements like buttoning buttons, or if they have trouble opening jars, they start dropping objects, together with trouble with the gait, imbalance. That's the most common symptoms from compression of the cervical spinal cord. Okay, so that's one of the conditions that requires further attention, a quick workup, and most of the times require a surgical intervention. Okay, that's for the cervical spine. There's also an issue when you have compression in the thoracic spine, thoracic cord. So in that scenario, you won't have trouble with your hands, but you're going to experience trouble with your lower extremities, with your legs. So patients, they might have issues with the strength of both legs, or they notice stiffening, some spasms, or dysfunction of the bladder and the bowel movements, or even they notice that they have what we call a sensory level. For example, they have numbness or less sensation from the nipples down. So those are situations where you think about maybe there's a compression of the spinal cord on the thoracic level. That's the second major group of symptoms patients should pay attention to. And if any of those symptoms are present, they should look for a physician to start the workup and see if there's indeed compression of the spinal cord.
Okay, thank you. Definitely some important symptoms to be aware of. So appreciate you walking us through that. Okay, Dr. Yoon, a question for you. What is spinal cord stimulation and when is it used? Is it an alternative to surgery?
Right. So spinal cord stimulators are devices which are actually very similar to cardiac pacemakers in terms of hardware. They're used to block signals, pain signals going to the brain from the spinal cord. And they're useful for patients who have chronic pain from, for example, failed back surgeries or from nerve root injuries. They're not used for compression of the spinal cord per se, although there is some promising research being done for restoring function using spinal cord stimulators for patients who have suffered paralysis due to a spinal cord injury. Is it an alternative to surgery? I have seen it used for certain patients where they're very high medical risk and they have nerve root compression, which would traditionally just decompress, but they may not be able to tolerate general anesthesia. And I've seen it used for that. What spinal cord stimulation you start with is a patient goes under a temporary trial with the electrical leads placed through needles. And then these leads come out through the skin and are attached to an external battery for a few days. And then the patient keeps a diary of their pain level with the device programmed. And if the pain is helped by 50% or more, then a permanent device is recommended. And the permanent device is completely implanted in the body, including the battery. All of that is under the skin.
Okay, well, thank you. And Dr. Stefanelli, is there anything else you want to add to spinal cord stimulation?
Yeah, I think Dr. Yoon did a good job covering it, but yeah, to reiterate, as he said, it's a good option for a lot of people with more chronic issues, generally speaking, and patients oftentimes that don't have what we call a structural problem. So I tell patients that it's great for people that have nerve damage or nerve pain and don't have compression of their nerves, that maybe a traditional decompressive surgery may be beneficial. But it's a very safe procedure. It's been around for 30 plus years, and a lot of people get a extraordinarily high amount of pain relief from it in the right setting. So it's definitely a good option for a lot of folks. But again, there's a lot of nuances to who it's good for, and it has to be trialed, as Dr. Yoon said, to see if it even works, because it isn't effective for everyone.
Okay, well, thank you both. And with that, let's go ahead and jump to our live questions that we're getting from the audience. So thank you all for submitting them. So I'll go ahead and just read it out. Whoever wants to jump in, feel free. So for the first one, is there a team approach to treatment with a group of doctors reviewing the patient file to determine the best action?
I would say yes. I mean, yes, but not in the sense you think about it. Like there's no, for your back, neck, spine issues, this is like bread and butter neurosurgery clinically. This is the patients that we see most commonly in the office. These are patients that, these are very common problems, right? So there's no multidisciplinary meeting where we're like, I'm in the same office as a pain management doctor and a physical therapist and a primary care doctor, and we're all like looking at your films together, right? These are things that are managed in a multidisciplinary manner, like with involvement of all those people, but like not like a tumor board or a focused group where we're like meeting to look at your films together, right? These are common things where you see a primary care doctor often. You may get referred to physical therapy, or somebody else may say, hey, you need an MRI, you get an MRI, you see a neurosurgeon, orthopedic surgeon. Orthopedic surgeon may send you to a pain management doctor for a trial of injections if that's appropriate. And we're kind of communicating through the medical record, and sometimes, personally, depending on the circumstances, but most of these cases are kind of, managed in a multidisciplinary manner, but like not like we're all in the same room, doing surgery together, on the same day.
Okay, thank you. All right, for our next question here, this person is asking, when a fusion is done, it sometimes weakens the discs above or below. Are there any developments in strengthening or protecting those areas post-surgery?
Yeah, I think that Dr. Holscher had alluded to this as well. So that's a good question. So we call that, when anyone has a fusion procedure done, what we warn patients about is that it could lead to, and I say could because not everybody develops it, something called adjacent segment disease or adjacent level disease. And essentially why that occurs is, if you imagine, as Dr. Holscher said, our spine is essentially a collection of joints. So when we do a fusion procedure, we are fusing one or several joints or levels together such that they don't move anymore, right? So, as you can imagine, as we all know, energy is not created or destroyed, it just moves somewhere else. So if you have mobile segments of your spine that are no longer allowed to move, your body is still placing those angular forces on that level. That energy that would normally be absorbed by the moving of that level gets distributed to the level above and the level below that fusion. So if you can imagine, it creates a situation where the levels adjacent or next to a fusion oftentimes will have quicker degeneration than if they were not next to a fused level, right? The things that we tell patients is, as Dr. Holscher said, keeping good strength, paraspinal musculature strong, physical therapy, keeping active, exercise, all of those things are the best way to prevent that from happening or to help prevent it from happening. And sometimes it's not preventable. There's also situations in the operating room where there's some techniques that we can do in very specific cases to, particularly when we're correcting deformities and scoliosis, to help lessen the effects of a long segment fusion on the adjacent levels. And those are like very technical things that we do in the operating room. But the general principles are keeping your core muscles strong, whether it be in your neck or your low back, avoiding unnecessary forces on your spine. So picking up heavy things inappropriately is not good for anybody's spine. It doesn't matter how old or young you are. So all of those things are a good way to help prevent that. But the reality is, in some folks, it just is not preventable. And it can also happen in patients that have not had a surgical fusion. Patients can oftentimes go on to what we call autofuse, meaning that their body actually fuses levels of their spine together in order to help get rid of arthritis or stop it from progressing. The levels above an autofusion your own body's doing can also break down. So it's something that we see quite frequently.
Okay, thank you so much. Very helpful. Next question here. We've received a few questions about your thoughts on chiropractic treatment.
I think I'll take that one. So when we're talking about especially back pain or neck pain, we have several non-surgical options we try before surgery if there's no an important cord compression. So I think some modalities like physical therapy, chiropractor, yoga, Pilates, aquatherapy, acupuncture, they're all very good options And what might work for one person might not be the ideal for the other person. And so that's why we try different modalities. Chiropractor, usually it's a very good option, especially for low back problems. There are also some different types of adjustments that are done for the neck, for neck problems. But especially if you don't have a very wide canal or you have a narrow canal that's limiting the space around the spinal cord, some of the adjustments done during a chiropractor section might be somewhat dangerous. So usually we tend to recommend to the patients chiropractor therapy for back problems. For neck problems, we are a little bit more conservative. And another reason is on your neck, you have two important arteries, the vertebral arteries that will provide the blood supply for the back of the brain, the posterior part of the brain. And there is an increased risk on those adjustments that someone can have an injury to one of those vessels. So I think chiropractor, in conclusion, chiropractor therapy, it's a very good option that we are more liberal in terms of low back pain, and we are a little bit more conservative in terms of neck problems.
Okay, thank you. Definitely some helpful and important distinctions there. Okay, so next question here. Know that we talked a little bit about robotic surgery earlier. This question says, when is robotic surgery not an option?
Yes, I can answer that. Some robots are just used again for the safe placement of pedicle screws, for example, in the thoracic or lumbar spine. I know that the particular robot that I use is not FDA cleared for placement of instrumentation in the cervical spine. So that would be an example of where at least the robot, again, I use is not supposed to be used in that region. There are other options, navigation, frameless stereotactic navigation is another technique that helps with placement of instrumentation that you can use in the cervical spine using the proper software, but it's not a robot per se. There are varying systems out there, and so I can't speak to each one, but there will be limitations in terms of where they can be used and if they're, again, FDA cleared for that type of use.
Okay, thank you. Another question here on minimal invasive surgery, as we also chatted about earlier. So this person is wondering, are there minimal invasive surgery to treat herniated disc or stenosis beyond age 65?
Yeah, I could answer that question. So generally speaking, age is not a determinant of when we cannot use minimally invasive techniques. What that depends more on are a couple of things. So the pathology, meaning the type of stenosis. So disc herniations can happen. I think Dr. Yoon had mentioned this, in all different parts of the spine, in the center of the spine, out to the side of the spine, coming out lateral to the spine, and push on all different parts of the nerves and the spinal cord. So a lot of minimally invasive techniques are dependent on the actual pathology itself. There are some things we can treat very well, minimally invasive ways, and there are things that we cannot treat that way. So that's number one. Generally, when folks are older, we tend to prefer less invasive procedures, just as a sort of rule of thumb about surgical risk factors. So when patients get older, we try to prevent doing much larger surgeries. Now, 65 is not old, obviously, but there's plenty of minimally invasive techniques we can use regardless of a person's age. A lot of it depends on the actual specifics of their case. And then, another thing depends on the surgeon's comfort. So not all surgeons do minimally invasive techniques, and some surgeons do some, and some surgeons do the bulk of their cases that way. So a lot of it depends on your surgeon's comfort with different techniques like anything else. So it's kind of a long answer to say that I hate to say it, but it really depends on a lot of different factors. But it is certainly an option for a lot of people, regardless of their age.
Okay, well, that's great to hear. Thank you. Okay, this next question is focused on the initial consult. So how do you decide on a surgical procedure and surgeon when you had 3 consults and each one was a different approach?
We get that a lot in spine. What I would tell you is spine is a little bit, it's a little bit different than some other problems in neurosurgery. For example, you see a patient with a big brain tumor, like there's really little decision making, like tumor's got to come out, right? You see someone with a bad traumatic spine fracture dislocation, there's no decision making, like it's got to be fixed, right? Um, Degenerative spine disease is as much art as science. And for some things are very straightforward. You might have a young patient with a large extruded L4-5 disc fragment, and 10 spine surgeons are going to mostly recommend the same thing there. Most patients that we see in clinic are not people with very focal problems. Most patients we see in clinic are, patients, the average patient we see in clinic is, I don't know, 60, 70 years old, has multi-level, let's just keep it restricted to the neck, for example, multi-level cervical degenerative disc disease. Every level has, a fair amount of degeneration. It's not like you look at the MRI and there's a singular problem, right? So one, you're teasing out which levels do you think are symptomatic. Do levels need to be fused, not fused? Would you come from an anterior approach or a posterior approach, a combined approach? And some of that will be influenced by, your training. Everyone has a little bit of bias. I trained and Dr. Stefanelli trained at Jefferson. There is some truth to having a Jefferson bias to how you do things, right? A guy that trained in Dallas, Texas, or a guy that trained in Los Angeles or somewhere else, or, Dr. Yoon trained at Temple, and he may have a different bias in how he approaches the spine. And so it's not uncommon for a fair amount of spine issues to get different opinions from different spine surgeons. And there's, at the end of the day, there's no substitute. You got to have a little bit of your own gestalt about, when you go to see someone, or do you trust that person? Do you think they're making decisions for good reasons? And are they able to, I always tell people having a good outcome from spine or any surgery is, can I take what you tell me, correlate it with what I see in your imaging, and then explain to you in pretty simple terms how I think surgery will change that natural history or that pathway, right? And if I can explain you to that pretty simply, by taking you through the films and telling you what surgery involves, well, then I think we can all expect that there's a decent chance. There's never a 100% guarantee, but there's a pretty good chance that if we can walk through that pathway pretty comfortably, that you're going to do well with surgery. And that pathway, admittedly, like in spine, there's different ways to get to the same point sometimes. And some guys might come, like I said, from the front. Some guys might do surgery from the back of the neck. Some guys might do 2 levels. Some guys might say, listen, that 3rd level I think is symptomatic. And it's sometimes very difficult to tease that out. And you're going to get different opinions. So I would just be prepared for that in spine. It's very common that if you get multiple opinions, that you may not get the same opinion from everyone, because it's just not as clean of a problem, for example, as looking at a scan and seeing a malignant tumor that needs to be removed. Like there's very little decision making there. Spine is full of very interesting little nuggets of decision making that people will have different opinions on.
Absolutely. And I think kind of a follow-up to that, this question here is asking, how would one choose between a neurosurgeon and an orthopedic surgeon for spinal surgery?
Yep, I'll take that one. Neurosurgery and ortho, they're different specialties with something in common. Spine surgery, I would say, it's a subspecialty within neurosurgery and also a subspecialty within orthopedic surgery. So I think both groups of professionals there tend to be well trained to execute and perform this type of surgeries. I would say there's no right answer if you should go to a neurosurgeon or to an orthopedic surgeon. I would say if they have the proper training, if they have the proper experience, the results should be as good for both of them. The one thing I would say, there's a nuance when it comes to tumors inside the spine canal, or spinal cord tumors, or tumors pushing against the spinal cord, that's usually those cases are referred to a neurosurgeon and not to a orthopedic surgeon. But the most common cases like disc herniations, lumbar stenosis, narrowing of the canal, those are typically treated both by an orthopedic surgeon and by neurosurgeon.
Yeah, Sarah, I think that's actually, this is such an important topic. If I may just piggyback off of this and really highlight it, because this is something that I think I have run into this exact question so many times. And it's actually a bias that you see in the community, not just amongst patients, but amongst referring providers like primary care doctors. A lot of people don't realize that neurosurgeons do spine. Like I can't tell you how many people have come up to me and be like, oh, I thought you guys only do brain. As like Dr. Matias said, there's for 95+% of spine problems, there is really no difference between a neurosurgeon and an orthopedic spine surgeon. If I may make a plug for neurosurgery, just because it seems to be like there's a little bit of less awareness in the community that neurosurgeons do a lot of spine. Our residency is 7 years long, and in our training, at least 50%, probably more of what we do is spine. So you cannot graduate an American neurosurgery residency without having done, I don't know what the average graduate does, but I'm sure the average graduating neurosurgery resident has done 700 or 800 spine operations. Like it is a core part of our training. That is actually not the case in orthopedic surgery. So if you want to avoid spine, like you can graduate an orthopedic residency and really not be totally comfortable or competent in spine and really focus your practice outside of spine. So I would tell you, anyone who graduates a neurosurgical residency is essentially ready for community spine practice. Like you really don't need a fellowship. You're so well trained in spine, you're ready to go. Just about everyone from the orthopedic side that goes into spine generally should do focused subspecialty training in spine after their residency to kind of get enough experience to be ready for practice. And frankly, if you take those two guys and put them 10 years out, there's no difference. Like an experienced orthopedic spine surgeon and a neurosurgeon are like 6 in one hand, half a dozen in the other. If I may make a plug for neurosurgery, I would just tell you it is so intrinsic to everything we do from day one that I tell patients like in our field, like spine is the minimum. It's like you can't graduate residency without being a very competent spine surgeon. And that's not necessarily true in orthopedics. And as Dr. Matias said, the other plug for neurosurgery is that the orthopedic guys will deal with, much like we do, like the 95% of the bread and butter stuff, but some of the more exotic, if you will, or kind of unusual problems in the spine when there are tumors in the spinal canal or issues where we have to go inside the spinal fluid space, like that is outside the training of an orthopedist. So if I may make a plug for neurosurgery, I would just say that we really do everything in the spine. Like nobody will ever be sent to me and I will tell them they have to go see an orthopedic spine surgeon. But there are problems where you will see an orthopedist and they will tell you have to go see a neurosurgeon. So, the reality is that for almost everything that people will encounter in their everyday life, it doesn't matter. There's a very small subset of things that require a neurosurgeon. As you can see here, I'm shamelessly making a plug for neurosurgery. Because I just feel like we are in our training, it is the complete spine training.
And I think that's a really helpful and important distinction. So thank you. All right, we have a few more questions and then we will go ahead and close out the evening. But just a few more live questions here. So whoever wants to chime in, but this person is wondering for thoughts about using inversion tables for spinal pain and compression relief.
Yeah, I can take that. Sometimes I'll actually refer patients to chiropractors, for example, who have these dynamic traction tables where there's a machine that literally stretches the spine and can create some negative pressure in the disc. Say a disc is bulging, it might be able to sort of allow that disc to come back in a bit. I've seen that help some patients. By the same token, an inversion table is doing just that too. It's creating negative pressure in that disc space. So it can definitely, at least temporarily, decompress compressed nerve root. But it's obviously not going to be sustained unless you couple that with core strengthening, which we've touched upon many times throughout tonight's webinar. So I think if you do that type of gravity dependent or machine dependent decompression, it has to be coupled with strengthening that core to maintain that decompression.
Okay, thank you. Yeah, definitely a theme throughout the night. Strong core. So appreciate the reminder there. Okay, next question here. This one's a little bit more specific. What are some options for numbness and pain around the cervical spine?
I'll take that one. It all depends on the what's causing the numbness and the pain. And I'll give you an example. If you have, for example, a disc herniation on your neck that is pushing against the nerve root, not the spinal cord, but the nerve root more to the side, and that's causing pain, shooting pain down your arm or radicular pain, together with numbness, the solution might be surgery, or before that we might try medications. There's a medication called gabapentin that's very gives very good results for radicular pain like this, for numbness, for tingling. So medications, or there are some pain doctors that they do injections on the neck area for radicular symptoms. Okay, so medications, injections, physical therapy, and eventually they might need surgery. So it all depends on the cause, or if the cause comes not from inside the neck, but outside on the nerves outside the spine, then it's a different way of looking at things. If there's compression, if it's an inflammation of the nerves. So answering to your question, it depends on the cause, but usually involves different modalities like medications, injections, or even surgery.
Okay, thank you so much. All right, this next question here. What are treatments for sciatica and sciatica nerve problems?
So I could take that. So sciatica is, to be quite honest, sort of a misnomer, that a lot of folks hear that term. Sciatica refers to the sciatic nerve, which is actually a collection of lumbar nerves after they've already left the lumbar spine. When folks say the term sciatica, what they're actually referring to is something called radiculopathy. So radiculopathy means compression of one of the exiting or multiple exiting nerve roots. So the spinal cord, as we talked about earlier, is kind of like the main wire. And at each level of the spine, a nerve leaves the wire. So you have, multiple spinal nerves. And when it occurs in the lumbar spine, so it can occur in any part of the spine, the neck, the mid-back, or the lumbar spine. But when it occurs in the lumbar spine, folks generally refer to it as sciatica, because that's kind of, those nerves will collectively form, some of the nerves will collectively form the sciatic nerve. So to make a long story short, any pinching of the nerves in the spine after they've already left the spinal cord can cause radiculopathy, which is the correct term for it. That's that shooting electrical type pain that folks are generally, pretty familiar with as we get older. The treatment options are vast and vary depending on, again, the cause of it. Treatment could be as simple as taking gabapentin or a steroid for just an acute flare-up. And the one thing I tell my patients that I'm sure we all do is that, almost 90% of acute sciatica or radiculopathy will resolve on their own with no intervention. So that's, I think, an important statement to make, is that most patients that have radiculopathy do not end up getting surgery. Now, it's the most common surgery that we do just by nature of the fact that it's a very common problem. But the reality is, even if we do nothing for most patients that have acute radiculopathy, it will resolve completely on its own. The things we try to help the pain in the interim are things like steroids. So your doctor may give you a Solumedrol dose pack, which folks have taken for a multitude of different reasons, colds, cough, stuff like that. That can help with acute sciatica or radiculopathy. things like gabapentin, medicines that are nerve modulating medicines to help with that pain acutely. And then, we talk about pain management. So generally the pain pills, things like opioids, aren't super effective for acute radiculopathy. The things why we generally send patients to pain management are for things called injections. So injections can help. They're targeted injections, usually at the nerve or a collection of the nerves in the spine to help cool that pain down. And of course, if patients fail those conservative things, including physical therapy, then we talk about surgery, and surgery can be vast. Because again, like I said, it depends on the type of pathology that exists. So long-winded answer to say that can happen anywhere in the spine. There's a million different treatments, but we generally try to do conservative things first. And most patients with acute sciatica or radiculopathy will get better without any intervention whatsoever.
And I think that's great news for many people listening. So thank you. Okay, we're going to do one last question, and then I have a question for myself, and we will close out the evening. So the last question here, this person is wondering, do any of you perform cervical laminoplasty, if I'm saying that correctly?
I mean, I won't speak for all of us, but I know at least 3 of us definitely do them. And I'm sure Dr. Yoon probably does as well. But Dr. Matthias, Dr. Holscher, and I trained together. So I know the 3, and I'm sure Dr. Yoon does them as well. It's a cervical laminoplasty is an alternative to a fusion procedure in the neck to relieve pressure off of the spinal cord. It's performed more often in other countries than it is in the United States, particularly in countries like Japan, just for whatever reason. But it's not an uncommon procedure. But again, the important thing to remember that it's not an option for everyone. So patients, to get a laminoplasty performed, they have to have a couple of things. So spinal cord compression is generally in the folks who it's effective for. Patients that, again, also do not have a lot of axial neck pain or mechanical neck pain, and that who otherwise have a relatively normally shaped spine. So the spine has different shapes depending on the part. I won't go too much into that, but you kind of have to have an otherwise normal spine with some stenosis and not a lot of mechanical pain to qualify for that procedure, or that patients will do well with that procedure. And it involves removing the back of the spine. If you think of it as there's like a couple different techniques, but essentially we create like a trap door where we drill a slot down one side of the spine, and then we drill all the way through the other side of the spine and open it up like a door. And then there's a host of, depending on what system we use, there's a host of different implants that will hold that door open, if that makes sense. So you're taking the canal, which is tiny, and you're opening the door on the back of it. So it keeps what we call the posterior elements or the back of the spine intact. It just opens the canal up. So it's not a fusion procedure. It preserves the normal cervical motion. It's generally for patients with spinal cord compression or cervical myelopathy, we call it. And there's only, a relatively small amount of people that we would recommend it for. But I think technically speaking, all of us, pretty much most neurosurgeons, spine surgeons are generally comfortable doing it, but obviously talk to your specific doc about it.
Okay. All right. Well, thank you so much. And with that, I'm going to jump to final question for this evening. So my final question for all of you is, what would you like our attendees to take away from this webinar? And are there any questions that you suggest patients ask their provider? So Dr. Matthias, we'll go ahead and start with you.
Okay. Yeah. First of all, thanks again for setting this up, for having us here. I think, one of the things I would like the people attending this will take home is, the major difference between spinal cord compression and nerve compression. The symptoms of especially the cervical spinal compression, loss of dexterity, hand weakness, trouble with balance, because that's a much more critical condition that most of the times require to be a little bit more aggressive on the management, and eventually ended up in surgery for cord compression. And for nerve compression, we have much more time and options, including medications, therapy, different modalities of therapy, injections. So 2 different problems when it comes to cord compression, especially on the neck, and when it comes to nerve compression, especially in the back.
Okay. Thank you so much. All right, Dr. Yoon, anything you would like our attendees to take away from tonight, and any potential questions you would like for them to ask their provider?
Sure, I completely agree with Dr. Matthias about making that distinction between spinal cord compression and nerve root compression. Sometimes those symptoms can overlap. And in fact, some patients even have compression more distally in the peripheral nerves that can cause numbness, pain, like carpal tunnel syndrome, for example. So it's important to sort of parse all that out. And then, I would want patients to ask questions like, what would happen if I didn't have surgery? There are some patients that don't necessarily need urgent surgery, and we could counsel them on whether, what that outlook would be if they don't have surgery. And if they do need surgery, what are the options? We talked about different approaches, and I think a lot of us here are adept at the different approaches, and some of us just have a preference for one over the other, depending on our training and our experience. So, to go over the pros and cons of each.
Okay, thank you. All right, Dr. Stefanelli.
Yeah, so again, thank you, Sarah, for getting this, moderating this and putting this together. Yeah, I think, again, echoing what everybody else is saying, two things I will add are, I think patients should not be afraid or should be more apt to seek counseling with a surgeon, ortho or neurosurgeon. And it's not because most patients will or are qualifying for surgery that they have a problem that is surgical, but oftentimes we can, we're sort of the experts on the problem, right? So we can point people in the right direction. So even if we're not offering surgery because we don't think it will help, we often have the knowledge to point people in the direction of, hey, I think you should get this type of injection, or I think you should do this type of therapy. So we can put patients in the right direction to get on track with getting their problem fixed. So I think that's one. And then the second thing I'll say is I always encourage patients, don't be afraid to, we talked about this briefly earlier, but don't be afraid to seek multiple opinions. I tell all my patients that's never going to hurt any of our feelings to get the opinions of multiple surgeons, because ultimately it's your body and you have to be comfortable, like Dr. Holscher said, with the person doing your surgery and in the relationship that you develop with your surgeon. So I think it's always good to see a couple of folks and understand what the problem is from different aspects and pick the person who you think is the best choice for you.
Absolutely. Okay, well, thank you. And Dr. Holscher, any final remarks and what you would like patients to take away from tonight?
Yeah, I mean, it's just, I think we've kind of touched upon it all. No one's going to walk away from this webinar being an expert on spinal cord versus nerve root compression or et cetera, right? So it's just, if you feel like you have a concern about that you may have an issue in your back or your neck, I agree with Dr. Stefanelli, like early involvement. I am happy to see patients in my clinic that haven't been through the so-called, conservative pathway yet. I like to actually quarterback that myself, meaning like I'll see people early. Like I've seen plenty of people that have not yet been through physical therapy or have not yet had injections, if that's appropriate, because sometimes it's not appropriate, right? And frankly, the best person to ask is going to be us as to whether or not this is a surgical problem or something that should be managed conservatively, at least at first. And to that end, I also agree with Dr. Stefanelli. Like I always highlight to people the importance of multiple opinions. If you have any doubt or question in your mind, I encourage everyone to get a second opinion. If you leave an office unsure of why you're being recommended surgery, if you go somewhere and you get 30 seconds of someone's time and they're telling you to sign a consent form, like go get another opinion. Even if it's, frankly, if it was me, I would always be getting a second opinion. So you should never be shy about that. It certainly is there's nothing wrong with it. Anyone who doesn't want you to get a second opinion is not someone you want to be moving forward with. So don't ever be shy about that. And I would encourage you to get at least one opinion at an academic center. So a lot of small group practices and a lot of really good surgeons in some small group practices. I would encourage you to get, an opinion from a place like Jefferson or another academic center in the area as well, because I think that sometimes you may find that you get a bit more of a conservative opinion at the university center sometimes than you get at the smaller community practices. So just keep that all in mind. And if you're in South Jersey, please feel free to come see me or one of my partners if you're on the Pennsylvania side of the bridge.
Okay, well, thank you all so much. Thank you to Dr. Matthias, Dr. Yoon, Dr. Stefanelli, and Dr. Holscher for your time this evening. I know a lot of great information was shared about spinal cord compression, research, treatment options, and so much more. And thank you all for attending and submitting such great questions. I know that I learned a ton, and it was a really interesting discussion. So thank you so much for your involvement. We will be posting an event survey, so you can let us know your thoughts. Your feedback will bring more virtual events like this to you, the patients. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please go ahead and fill out the last question in the event survey. A recording of this event will also be sent to you so you can rewatch at your convenience. And if you would like to view other wellness webinar series events, please visit our Jefferson Health YouTube channel at youtube.com/Jefferson Hospital. We have everything from men's and women's health to robotic surgery to planning for pregnancy and much more. If there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. We hope you have a wonderful evening. Thank you.